Okay, so I'll just give you the hand then. So again, my name is Will Kennedy, and I live in practice in Portland, Oregon, and I work at the state's largest safety net health plan. But we also have merged and partner with House Call Providers, which is a mission-driven, community-based primary care, palliative care, and hospice care organization. And so what I'll talk about for the next 15 minutes is really the spectrum of those areas, so it makes more sense. And it's also about a learning journey that I've been on for the last 20 years. And so I was a fourth-year medical student walking down the street in Boston, and for whatever reason that day, I happened to have a camera with black and white film in it. And I looked up and saw this gentleman, and it stopped me in my tracks. And I just stood there, I think probably not moving, looking at him, because I'd never seen a sight of greater despair than that moment. And he's looking down, and as you can see, he doesn't have a sign, he's not asking for anything. It's just pure despair. And because he was looking down, I could take a photo to remember the moment. And so I actually framed the photo, and it's been on my apartment wall and my office wall, and right now it's up in our palliative care office wall in Oregon. And it's been there for 20 years as a guide, because I was so struck at this gentleman about how did he get into this place? How could we help him? Because even then, at that moment 20 years ago, I knew that there were people that wanted to help him, but it just wasn't clear how to do it. So this is what's been my journey over that time. Okay, next slide. So about 10 years ago, so I had already finished my training and done my fellowship and started doing hospice and palliative medicine clinical work. I read this quote, and this is by Bill Gates, and this was his observations on going from being the CEO to Microsoft to transitioning to full-time in the philanthropic world, and his recognition of the gross health inequities in the world. And you can see it here. All of us here in this yard at one time or another have seen human tragedies that have broke our hearts, and yet we did nothing. Not because we didn't care, but because we didn't know what to do. If we had known how to help, we would have acted. The barrier to change is not too little caring. It is too much complexity. And that was the first part and the first learning for me of trying to unravel these lives that we work with now on a daily basis about what complexity means and how it blocks us in taking care of them. Okay, next slide. So this is a story, an Oregon story, and I'll just read it for you here, and we'll end up with this as well. So this is the story of Paul, 50 years old, diagnosed with metastatic lung cancer. He had a vague history of leaving the hospital against medical advice, which was never clear in the records why he was doing it. No one knew. He had had a difficult life, job loss, addiction, divorce. He was estranged from his children. And as he described it, his life went into a downward spiral. He was physically frail, even though he was only 50 years old. And he lived an isolated life in a single-room hotel. And he agreed to aggressive care, as he described it in retrospect, without understanding that it would never cure him. And he had a series of complications during the therapy. He had a heart attack. He lost his housing because he didn't have anyone to pay the rent while he was having his prolonged hospital stay from the complications. And eventually the medical team, as he described it, walked in one day and said, "You know, Paul, there's nothing more we can do." And so surprisingly, he accepted this. He was very angry, but he accepted it. But he also said, "I'm not going to go to hospice. That's giving up." And so the question becomes, what do we do with people like Paul? How do we serve them? How do we meet their needs? So next slide, please. So in the traditional palliative care world, we think of palliative care in three pillars: care coordination, symptom management, and identifying goals of care. But if you think about Paul's story, think about how those three pillars, however important they are, do not account for the complexities of his life, his isolation, his difficult history, his ambivalent goals of care, and so forth. Okay, next slide. So in the work that we do, the way we describe it as those pillars still exist. They're still important. But at the center of the work and unpacking and helping Paul in the ways that he needs is about developing a therapeutic relationship with him. And essentially working with him in a life where he has not had the type of support and relationships that would help him deal with a situation like he's in now. And so much of our work is providing clinical, longitudinal, highly skilled interventions where these relationships are built with the understanding that we walk with people for the duration. Okay, next slide. And so in so many of the patients that we serve, when you get to know them, and CareOregon, where I work, has done qualitative research on many of the patients. It's certainly consistent with the literature. It's certainly consistent in populations who are dealing with the most complex type of problems, which involve the overlap of behavioral health, medical complexity, and social determinant problems, is that traumatic life experience is a key part of that history, especially in childhood, but certainly in adult as well. And of course, that leads to all of the things that we think about that we find so challenging to deal with when we're trying to help somebody in this situation, right? The psychological issues, the isolation, the estrangement from relationships that would help them, hypervigilance, PTSD, anxiety, depression, so forth. Okay, next slide. So this is by Bruce Perry, who's a psychiatrist and an expert on trauma. And what he describes is relationships are the agents of change, and the most powerful therapy is human love. And the part I want to emphasize is relationships as agents of change, that they are an essential ingredient to helping people, right? They're not something that we can consider something that's applied on a short-term basis, walking in and out of somebody's life. For these folks, it is essential that they are there as a trusting, stabilizing force in their lives. Okay, next slide. So this is Maslow's hierarchy, but put on an XY graph, right? And you'll see on the left, and it's also very colorful, as you'll see on the left, the green would be on the bottom of the triangle as it's usually seen, which are the basic needs, social determinant needs. And then you work your way across. And the idea is that when you serve people who have very complex problems, is that you need to meet their basic human needs first before you can even talk about things like goals of care or medical interventions and these issues. And I see that again and again that's missed. A colleague has a powerful story saying that she was about to walk in and tell somebody who had just been diagnosed, walks in the hospital with a cough, diagnosed with stage 4 cancer, untreatable, and they're preparing themselves to walk in and give her the bad news. And the patient stops them in the middle of the presentation and says, look, this is the least of my problems. I'm worried about where I'm going to sleep tonight, right? So there's an acknowledgement that if these things are not met in sequence, we can't help people in the ways that they need it. Okay, next slide. So these are the kind of issues that we tend to think about. And I would say as a clinician, these are the things that hit you in the face and that jam you when you're trying to take care of patients. The things that we all know. Mental health issues, either current or past substance use problems, lack of social supports, which also means things like lack of proxy decision makers, food insecurity, it's been talked about a lot today, housing, obviously. Health literacy, I think, is a great one always in the room to be thinking about. So those are the ones we think about, but what are the ones that are there that are part of the patient experience historically that we don't think about? And I can tell you that when I went from full-time clinical medicine and then came to CareOregon and sat, my office essentially was on the case management floor for a couple of years, and hearing all the case managers work every day, I realized this entire new world of barriers that I had never been aware of. Okay, next slide. And so go ahead through hidden barriers. And these are the kind of things that truly, truly stop people from getting care, from the social services that they need. No insurance, complicated eligibility requirements, discrimination, cultural incompetence, disorganized services, inaccessible service locations, provider attitudes, distrust, bad experiences, disabilities, no documents or transportation, language, illiteracy, disorganized lifestyle, and of course, complex health problems. And I can tell you the one that stood out to me that I could not get over when I heard that would happen again and again is how many people have no ID to show who they are and how they cannot access social services because they cannot prove who they are. Imagine being in that situation and having all the complex problems that you have. Next slide. So I want to pause in this and talking about just today as we're talking about how do we bring together health care with social services. And one of the things I've learned along with this idea of developing therapeutic relationships is that there are skills and tools that help broach this chasm. And one of them is motivational interviewing. And if you don't know about motivational interviewing, it's from the behavioral health world. And it's a simple idea, at least in the way I think about it, which is that it's unearthing the conflicts, the ambivalence that we have, and bringing them to the surface for people to help them make decisions. And people that have lived traumatic lives, this is a very common part of their lives. And the second part is around specialized tools that serve people. And one of them is we use the ACP decisions videos, which are highly curated, short 5 to 7 minute videos that show people information and help broach health literacy issues. I have seen dramatic differences in applying these tools in our populations. Next step. So this is one of the ways that we have seen the problems and tried to address them. And so Lauren Taylor said this morning, and I remember in her literature review, I think as she said it, was that the three things that stood out to her were housing, case management, and visiting the home. And so that immediately resonated with where we've come in doing this work for years. And so this is last year, CareOregon merged with House Call Providers, this is the day that we merged. And this is a mission-driven organization that serves almost 2,000 vulnerable Portland-based Oregonians every day across primary care, palliative care, and hospice, in the home, in other settings, including people that are homeless, as a way of building those relationships and identifying all manner of needs that are only identified through the relationship and being in the home. Okay, next slide. And this is also another thing that Lauren mentioned this morning. This is the Blackburn Building, which will be opening in 6 to 8 months. This is on the east side of Portland, and that is a 5-story building. The top 2 floors will be supportive housing for the homeless. The bottom 2 floors will be a full-scale federally qualified health center, including behavioral health, so mental illness support, addiction support, and full-scale primary care on the bottom 2 floors. And on the middle floor will be housing, supportive housing, medical respite housing for people coming out of the hospital who are homeless. But the special part is that on that floor, there will be 10 dedicated beds for end-of-life care in the homeless. And to our knowledge, this is the first from the ground-up build in the country focusing on this. And of course, that will be essentially building something where social services and healthcare can serve people, because for these populations, it really has to be there for them. So, next slide. So, in thinking about Paul, he lived with terminal cancer. He refused hospice. He was isolated. He walked out of the hospital for unclear reasons. Our palliative care team worked with him, walked with him, built trust with the understanding that he was never going to go to hospice and that they would be with him till the end, right? Which is a common scenario in our population. Eventually, he disclosed that his uncle had abused him as a child, and so when he would be in the hospital at night, a male nurse would come in, would trigger him, and he would leave, and no one would know what would happen, right? And this led to his own healing and his further attachment and bonding with the care team. And before he died in supportive housing, he said, "I used to be falling, and now I am not." He experienced a peaceful death. Thank you.